Hello, team. I'm Alex Sabo. I'm the chair of psychiatry and the program director of the psychiatry residency training program. And I'm here with Ron Hayden, the director of our emergency services. And we wanted to talk a little bit about the issue of evaluating the intoxicated patient in the emergency room. Issues around capacity, serum levels of alcohol, capacity to make decisions, suicide assessments of the intoxicated patient. And Dr. Hayden is an expert in emergency medicine, and he and his team see many, many intoxicated patients that we never see. And we want to start with how Ron approaches this. So.
Okay, thanks, Alex. One of the things I'd like to bring up is we do see a large volume of intoxicated patients, and not just intoxicated patients coming in with a behavioral health issue, you know, a suicide statement, a depression statement, other things. We see trauma in alcohol, we see medical complaints in alcohol, so we see on a day-to-day basis any number of patients will come in with all different degrees of not only alcohol intoxication, but also other drug-related inebriation. So we see a wide gamut of these patients, so we're very familiar with this subset of patients. I think the most important thing for us is to make a clinical decision if the patient is intoxicated or under the influence of some drug that is impairing our ability to assess them. So for that trauma patient that comes in that is severely intoxicated, I'm not sure they have valid complaints of pain or complaints, and I have to wait till they're at a point where they are clinically sober where I can make that best determination. So that means holding them or make sure they're handed off to a trauma service or somebody else that can more fully evaluate them when they're quote-unquote clinically sober. Because clinically sober it's not a number. You can be an adolescent with an alcohol level of 80 being completely intoxicated. But you can be a chronic alcohol level or a chronic alcoholic with an alcohol level of 200, and that's your day-to-day functioning norm.
Could you just say that one more time? Because I think that's a really important point.
It's tolerance and dependence, especially with alcohol. I mean, these chronic alcoholics, I mean, if you've worked in this arena as long as I have, I've seen walking, talking, coherent alcoholics with levels of 600. I mean, these patients are chronic drinkers, have been drinking for a long time. By the time they get down to 80 or 100, which seems to be a magic number for some reason, they're in withdrawal at that point. And then you've got a clinically unstable patient at 100, where I had a clinical stable patient who was probably as lucid as he's going to be at a level of 200 or 220, whatever that may be. So correlating the number to the patient is not a good correlation whatsoever.
So how do you do it? What are you looking for?
You do it on your mental status exam. You do it on some physical signs. So if the patient comes in and they obviously have slurred speech, they can't focus on the conversation, their eyes are drifting, there's nystagmus, they're stumbling, they have no coordination, finger to nose is all over the place, anything that's, you know, cerebellar signs. There's many things you can do on a quick evaluation that says this guy is too intoxicated to go anywhere. I can't do a good clinical assessment, I can't do a good trauma assessment, I can't do a good mental status exam, and I can't do a suicide assessment on this guy. He is just too inebriated to make any decisions at this point. That's not to say you still don't see the patient at that point in time, because as you know, with alcohol and other drugs, when these patients are disinhibited, they can bring in a variety of issues and complaints that otherwise you may have not heard. You know, when they sober up, they say, well, that really didn't happen, but in reality, when they're disinhibited with the alcohol, there's things going on in their life that they're willing to bring up at that point of inebriation, and they're unwilling to speak about it when they're quote-unquote more sober. So there is some value of hearing what they have to say and then validating that later when they are clinically more sober, or disproving that later when they're more sober. So the way we approach these folks is, one, make that assessment, that clinical assessment, whether they're too intoxicated to make any rational determination. So we err on the safe side of trauma, err on the safe side of diagnostic workups, aim on the safe side of restraining if we have to. They can't leave. The family can't take them home if they're too intoxicated that I can't make an assessment. And then we essentially need to watch them and observe them until they get to a point where I feel that clinical assessment can be valid. The alcohol level comes down, the speech clears up, the gait gets more stable, they get up, they go to the bathroom, they're clinically stable. Then I can readdress their physical complaints, their symptoms, or their mental status complaints, or their depression, or their suicidal ideation, and make an assessment at that point, whether I feel they are coherent and reliable enough to take a history and an examination I'm comfortable with, and can make a disposition at that point. I don't hold them till their alcohol levels are back down to 80 or 50. Some of these people would be there 24 hours.
Sure.
Waiting for that to happen.
You've really given us a lot of important information in a brief time. I'm just going to try to summarize what I think I heard. One, that serial evaluations of somebody who's intoxicated can be helpful. They don't have to be long, but they can be brief and very focused in order to get a sense of where this person's at. One, you're saying that sometimes in the intoxicated state, somebody brings forth some information that would be useful to know and talk with them about later when they're more sober. So that's one important thing. Second, you're looking for intoxication by sort of three major methods. It sounds like slurred speech, maybe four methods: level of arousal, lateral gaze nystagmus, and some kind of cerebellar ataxia. It could be finger to nose or their gait if you're watching it. Those are kind of the levels that you're looking at. So arousal, lateral gaze nystagmus, slurred speech, and some kind of ataxia. The blood alcohol levels themselves are only rough guides that are totally dependent on how much exposure the patient's used to. You know, a heavy alcoholic over many years could be sober really at a blood alcohol of 200, and at 100 they'll go into withdrawal, whereas a novice might be very intoxicated at 80 to 100.
Correct.
So that's what you're looking for. Is there anything else that we should kind of take home when we do these assessments?
Well, I think one of the challenges we have, I mean, a lot of these patients, when they present for a variety of reasons, we're evaluating once they're clinically sober and we feel they're either, can be released on their own recognizance. Of course, you say you cannot drive, and if they plan on driving, we will make some type of arrangement so they aren't driving. They can be released to, family or friends that are personally going to take responsibility for them, and they have capacity to do that. But then the other thing is, who are we handing them off? Are we handing them off to the trauma service? Are we handing them off to behavioral health? Are we handing them off to the medicine service? So when that handoff has to happen, there has to be a fairly degree of certainty that you've got a clinically sober patient that you've fully evaluated. So I'm not handing them off to another professional who's going to say, wow, I never expected this, or I couldn't make that determination because of the level of intoxication. So we try to avoid that and work as a team to make sure we're agreeing on the clinical sobriety of the patient at the time of that handoff.
And I would say for our trainees, whether they're master's level clinicians who are getting new to emergency room work or residents in psychiatry, it'd be useful to examine some of these patients, kind of quickly and effectively by looking for those four levels of the level of arousal, the lateral gaze nystagmus, slurred speech, and some form of ataxia, and then noticing when the patient becomes clearer and those signs melt away. And they're going to melt away at various serum levels of alcohol, according to the patient's condition.
That is correct. I mean, if I see the patient is so stuporous from alcohol, you can't get any history, it doesn't make sense for me to ask you to see that patient because nobody's going to get any information.
Yeah.
But if the patients come in and they're talking, they're expressing anger and distress and depression about it, and they've thought of suicide, even though they're intoxicated, I think that's important information to hear up front.
Yes.
Again, I still need them to clear a little bit,
Yeah.
because alcohol speaks a lot of different languages. So,
Yes.
and until you've got that alcohol level to come down far enough where the patient says, no, I feel so stupid about this. Every time I drink too much, I do the same thing. And you corroborate that with some family or some friends, and then everybody feels better about the non-reality of that potential. But sometimes that potential will get buried and get hidden when the patient's more sober because they're embarrassed and they didn't want this information coming out in the heat of the moment. So.
Right. And so, Ron, you just added another really important thing, getting that third-party corroboration of something that's come up in the assessment can also be important to the safe assessment. So
sometimes you can get that, sometimes you can't. I mean, a lot of these people, especially with the chronicity of their disease, have burned a lot of relationships, and sometimes it's really hard to get that back. But there's others that are, will stand by these people in thick and thin and say, they're at it again, or for all these reasons, but we've got support systems to help them, or we need support from you guys to help us.
So thanks, Ron. I think this will be really helpful as we all get on the same page with these assessments, good handoffs, and good care for these patients. Thank you.
Great.